It's December. I'd like to wish everybody listening a non-denominational generic seasonal greeting and remind you that you still have time to buy me a Christmas present. This year I'm asking for some high-end Bose noise-canceling headphones. So get on it. That's you, Evan. I deserve it for all those curbsides. It's another Persiflager's podcast review the infectious disease literature with commentary for December 1 through 15, 2007, the penultimate podcast of the year. This is on iTunes, as you probably know, but if you like it, log on and write me a review. This is brought to you by Puscast, LLC, the publisher of the Persiflager's annotated compendium of infectious disease facts, dogma, and opinion. Your uber-hyperlinked guide to infectious diseases at Puscast.com. Because this is CME accredited, I have to mention that I have no conflicts of interest. I also need to mention that all the opinions are those of Puscast LLC and have nothing to do with legacy health systems. And because it's CME accredited, you can log on to the website, get free CME by answering 3 simple questions, one of which is not what is your favorite color. If you like this, of course, I also have a podcast on complementary and alternative medicine, the Quackcast, that is available on iTunes. And I'm sure you listened to my pathetic plea to be involved in the ID Wiki book. If you know anything about infectious diseases, log on and join the wiki. And now on to the ID literature. This month has a lot of little things, but no great earth-shattering. So I think, firstly, everything I'm going to say is going to take about 30 seconds per report. 2 studies that were reported on Medscape, which were from the 2007 HIV Prevention Conference, one of which looked at, of all things, fatalism and how it impacted HIV care. They took 316 clinical providers of HIV disease, and they gave them a survey that measured fatalism. A lot of people were convinced that taking the test would cause their death, but they took it anyway. But the survey on fatalism was correlated with how well patients received care for prevention of HIV as well as long-term counseling. So patients were more likely, if their provider was fatalistic about the results of HIV, to have less counseling about high-risk behaviors and risk reduction. So if your provider has Bobby McFerrin's Don't Worry, Be Happy, you're in a good hands. If they're playing lots of The Cure or Morrissey, maybe you better seek care elsewhere. Everyone who treats HIV has had to deal with the issue of lipodystrophy syndromes with fat redistribution and elevated lipids, and therapies have been pretty unimpressive to date. In the New England Journal of Medicine this month, they looked at the results of a growth hormone-releasing factor, tesamorelin, which is given subcutaneously once a day for patients for 26 weeks. Interestingly enough, those who got this had a decrease in their adipose tissue by 15%, whereas those who received placebo had their fat increase by 5%. I'm sure it would make my brain shrink to use it. Also, levels of triglycerides went down by 50 milligrams per deciliter in the tesamorelin group, and the ratio improved as well. So this would appear to have a significant effect on both the lipodystrophy of HIV as well as the lipid profiles. The interesting thing about tesamorelin, assuming I am pronouncing it correctly, is that it's highly specific for the visceral fat and has little effect on either the fat in the limbs or subcutaneous fat, and it does not mess with glucose control. Perhaps it would be a benefit with all the fatheads that currently run the country, or maybe not. Now, the big problem with lipids, of course, is vasculopathy, and I am the master of the segue. This was an article that looked at HIV-related stroke and found that while they were often very young, 33.4 years was the mean in this cohort of 67 HIV patients, they did have strokes nonetheless, and it was often due to vasculopathy of one sort or another. Now, pay attention here. The interesting thing was that 37% of the patients with HIV-infected strokes had a recent or intercurrent opportunistic infection. That will lead into a paper I'm going to talk about a little later in the podcast. But be that as it may, when patients with HIV have strokes, they're likely to have some sort of vasculopathy as a cause. And it's worth working them up for potentially reversible vascular etiologies of their stroke. Unless, of course, like in the first paper we talked about, you're fatalistic, and so you probably won't do anything. Don't worry. Be happy. See, it all ties together in the great big cosmic goo. Now, different HIV medications can have different effects on patients, and some patients have different manifestations of HIV. For example, if you have a lot of HIV replication in your CNS, you may have HIV-related dementia and other neurocognitive disorders. In this study, they took a series of patients who were going to be started on antiretrovirals and put them on lopinavir-ritonavir therapy alone before adding their subsequent drugs, and then looked at the results in their spinal fluid of the effect of lopinavir on the multiplication of HIV in the CSF. And they found in these patients that HIV viral load was reduced by about 1.4 logs on average, and this was just on the lopinavir. So it is one of the drugs to consider giving someone who has CNS manifestations of HIV. Chikungunya. I love saying chikungunya. It's a viral infection that causes fevers and arthritis, and it's been primarily spread by a mosquito, the Aedes aegypti mosquito. It can cause huge outbreaks. For example, in Reunion Island, it infected a third of the population, 266,000 people, and killed about 260. However, it has now been spread from the common mosquito to a new one, as reported in the Public Library of Science Journal. It now can be carried in the Asian tiger mosquito, thanks to a single mutation in the virus that allowed it to use this mosquito as its transportation device. The Asian tiger mosquito is found throughout Europe and the Americas. I believe, though do not know for sure, that it came over to the United States, it is thought, in tanker ships. But if the virus makes it over here, it's an arbovirus, by the way, in the blood of an infected human, for example, it has mosquitoes here in North America and Europe, the Asian tiger mosquito, by which it could become endemic in parts of the world where it was never seen before. Yes, it's all well and good, I like to say, chikungunya. But what about real infections that you have to deal with on a daily basis, you ask? What about hepatitis B? This study was published in the Annals of Internal Medicine and compared telbivudine versus adofovir in the treatment of patients who are hepatitis B positive. And when compared at 26 weeks and 52 weeks, the telbivudine group had a superior response. For example, the baseline DNA for hepatitis B fell 6.3 logs in the telbivudine group versus 4.97, which is basically 5, in the adofovir group. More patients, by a factor of 3, became HBV DNA PCR negative, and twice as many patients lost their E antigenemia. So in this 1-year follow-up of patients with chronic hepatitis B, telbivudine was superior to adofovir. Breakthrough did occur in both wings of the study. There were 4 in the adofovir recipients and 3 in the telbivudine recipients. And those that broke through in the telbivudine group had what they call the signature resistance mutation, which is at the M204I, for those of you who are interested in alphabet soups. The downside to every hepatitis B treatment has been so far that resistance does occur long-term on these agents. One would bet that eventually we're going to slip into the multi-drug therapies like we do for HIV, but those studies have yet to be published to my knowledge. Shingles has long been an unpleasant disease, but if you're immunoincompetent, it may be worse than unpleasant. This study looked at the incidence of shingles in patients with organ transplantation at the Mayo Clinic between the year 2001 and 2004. There were 2 interesting take-home messages from this study, one of which is that the average incidence was 28 per 1,000 person years for developing zoster. But the interesting thing was that for every decade of life, your risk of zoster went up 1.5 times, and your likelihood of developing zoster was highest if you were seronegative for varicella zoster. So if you're an old person who is seronegative because your immunity has waned to varicella zoster, your chance of getting shingles is high. Now, I could be wrong about this, but I think we have a vaccine that's very effective in preventing zoster. And perhaps if you had a patient who is less than 65 and was seronegative for Zoster, who was hidden for a kidney transplant, you might want to consider giving them the vaccine. Romeo and Juliet had it wrong. It wasn't a plague on both your houses. It was a plague in all our houses. And the plague is that of boils, and those specifically of Staph aureus. What's the best treatment for Staph aureus boils? Well, it's surgical I&D. What does antibiotics add to the cure rates? This study looked at patients who were randomized to placebo or cephalexin, the majority of which had MRSA as the cause of their boil. And they found that patients who had placebo had a 90% cure rate versus those who had cephalexin, which had an 84% cure rate. So basically, placebo versus placebo, since most of these were MRSA, did not do anything for the cure of abscesses and boils in the majority of patients. However, in some studies that have compared doxycycline versus TMP sulfa, talked about several podcasts ago, there were no failures in the doxycycline-treated group, and there were just a smattering of failures in the TMP group, probably because they dosed the TMP sulfa at the homeopathic dosing of 1 PO/BID. And so 90% of patients with boils don't need antibiotics to get better, and you're probably only breeding resistance to tetracyclines and TMP sulfa if you treat it. 10% do need therapies to help get them better. The question is, which patients in the group who fail would benefit from antibiotics? I'm sure that study is being done even as I speak. It will be published in the future. But the old clinical dictum still hold: nothing heals like cold steel, and a chance to cut is a chance to cure. Starting next year, we're not going to get paid for nosocomial infections of a variety of types. And so we're trying to figure out how to predict who is going to have a hospital-acquired infection. Some centers are looking at MRSA colonization of the nose. And some of the questions that arise with this is, what does that mean? In this study, which was published in the Journal of Clinical Microbiology, they looked at almost 6,000 MRSA isolates and tried to predict what they meant. I think, interestingly, that if you had MRSA as colonization, you were more likely to have resistant other organisms, something I would not have predicted. You're also more likely to have MRSA in a wound, which does not surprise me. The other interesting thing is that the negative culture for colonization was bad at predicting MRSA-infected patients, and that a third of MRSA-infected patients were not nasally colonized. Now, we've talked about other studies on this podcast to show that the retropharynx and the stool are other places the patient can be colonized with MRSA. But the presence or absence of MRSA in the nose does not necessarily rule out MRSA disease in the setting of high or moderate prevalence, which is basically the whole world. I'm starting to think that our approach to patients to the hospital should be to put everybody into permanent isolation, although I doubt this would be economically and practically feasible. However, MRSA colonization is an issue that will be coming at your hospital, and what to do about it, I think, still remains problematic. And this is also problematic in that the motto of infectious diseases is use it and lose it. Prior podcasts have talked about the daptomycin studies that have showed the use of daptomycin leads to daptomycin resistance on therapy for patients with bacteremia and right-sided endocarditis. This study looked at prior vancomycin use and subsequent MICs to vancomycin, and they found that if you had been on prior vancomycin in the prior 30 days, that if you had MRSA in your bloodstream, you are more likely to have a higher MIC, and you are more likely to have decreased vancomycin killing in the test tube. So prior daptomycin predicts daptomycin resistance, and prior vancomycin, while not necessarily leading to vancomycin resistance per se, will increase the MIC and will slow the ability of that drug to kill organisms. So if you have a relapsing MRSA infection, it may not be a good idea to continue the vancomycin, but breed resistance with another antibiotic. Because face it, no matter what you do right now with staph, you're going to fail in your therapy and you're going to breed resistance, and we're slowly, inexorably sliding into the post-antibiotic era. And again, infectious diseases will become, like it was in the old days, a surgical subspecialty, and that if you can't cut it out, you can't cure it. To give you an idea of the morbidity of MRSA, the Emerging Infectious Diseases looked at the estimated number of MRSA hospitalizations from 1999 to 2005. They estimated that the number went up 62% from 294,000 to 478,000, which is pretty impressive. The good side is that we're doing a little better, and death rates fell during this time from 3.7% of patients admitted with Staph aureus to 2.4%. So you're less likely to die even if the infections are getting harder to kill. That, of course, is to the excellent care that infectious disease doctors provide. Don't forget, get your ID consult now. I remember back when I was a resident 21 years ago, we treated all our patients with acute sinusitis with 14 days of antibiotics. Now, since that time, the duration of antibiotic for the treatment of acute sinusitis has fallen from 14 days, was effective as 10 days, was as effective as 7 days, was as effective as 3 days. Can you predict where that trend line is going? This study was published in JAMA. It was a double-blind, randomized, placebo-controlled trial, the classic best type, which looked at acute, non-recurrent sinusitis. Patients were randomized to get, and here I quote from the study, antibiotic and nasal steroid, placebo antibiotic and nasal steroid, antibiotic and placebo nasal steroid, or finally placebo antibiotic and placebo nasal steroid. And guess what? For acute sinusitis, they were all the same. They didn't do diddly. And everybody was symptomatic for the same duration of time. So antibiotics or steroids don't help in the treatment of acute sinusitis. There have been other studies to show that antibiotics don't alter the course of acute sinusitis, so this is not the first one. Now, they used amoxicillin as their antibiotic, and it could be argued in this era of increasing resistance that amoxicillin was the wrong choice. I think every antibiotic is the wrong choice for acute sinusitis, in large part because snot levels of antibiotics are not very good, and you don't get good antibiotic penetration into there. And one would expect that the best you could do would be breed resistance rather than get rid of infection, especially with the piddly-ass doses that most people give for oral antibiotics. Is this going to change anyone's behavior? Probably not. Are patients still going to demand antibiotics? Probably. Are people going to give probably more expensive and useless antibiotics? Probably. Is resistance only going to get worse? Probably. Is the world going to hell in a handbasket? Probably. But I take solace in the fact that there are 6,000-year-old Sumerian tablets that say the same thing, that the world's going to hell in a handbasket and the young people today don't care, and nobody learns from experience or respects their elders. So the more things change, the more they stay the same. Sometimes I wish I was a homeopathic physician, then I'd never have to learn anything, and I could do the same dumbass thing year after year. Now, last podcast we talked about the treatment of meningitis and how glycerol was better than dexamethasone in meningitis in children. Now there are 2 studies in the New England Journal of Medicine that looked at the use of dexamethasone. One was in Vietnamese adolescents with bacterial meningitis, and they were randomized to get dexamethasone or placebo for their bacterial meningitis. And they found that dexamethasone did not improve the outcome in patients with meningitis unless patients had microbiologically proven disease. The other study was done in Africa and looked at bacterial meningitis, this time in adults, and found again that dexamethasone in an area where the vast majority of patients had HIV disease, that dexamethasone did not alter morbidity or mortality. So who then should get steroids for their bacterial meningitis? Well, kids with Haemophilus B is one group that benefits, and adults with positive gram stains, i.e. those who are going to have a microbiologic proven cure. Whether everyone or not should get glycerol instead is yet to be done in adults, as the original study was done in kids. So what to do for bacterial meningitis, like so much of medicine after so many years, still remains confusing. God, I wish I was a homeopath. And I suppose another question is, are you going to do harm by giving steroids? In the sub-Saharan African study, the answer is no, that the effects look to be the same in whether or not the patient received placebo or corticosteroids in terms of 30-day mortality. In the study that was done in Vietnam, in patients with meningitis that was bacterially proven, the 30-day mortality rate was lower in the dexamethasone group in the definite bacterial meningitis compared to placebo, while in the probable bacterial meningitis, the 30-day mortality rate was less in the placebo group compared to the dexamethasone group. I think that says that the overall effect was 0 at 30 days. In none of the cases, however, was the difference statistically significant, the most being 0.03 for the superiority of dexamethasone in the definite bacterial meningitis group. So overall, I think the effects of corticosteroids in bacterial meningitis remain problematic at best. Is there anybody out there that knows statistics? Because I sure don't get this study. This was a study that looked at cough in children that was published in the pediatric literature. And they compared honey versus honey-flavored dextromethorphan versus nothing in the treatment of nighttime cough in children who had upper respiratory tract infections. And they found that honey was superior. However, and this is the part of the statistics that I don't get, when you compare honey to nothing, honey is superior. When you compare dextromethorphan to nothing, there's no difference. But when you compare honey to dextromethorphan, there's no difference. So, what's the better treatment? Honey is better than nothing, but honey is equal to dextromethorphan, but dextromethorphan is as good as nothing. I hate statistics. My brain hurts. All I can say is that maybe honey helps your kid's nocturnal cough, and he'll sleep better compared to dextromethorphan, which was honey-flavored. But I don't know. My head hurts. I'm going to go take a Tylenol. So how good's your memory? Can you remember 20 minutes ago when I was talking about strokes and AIDS patients, most of whom had concurrent infectious diseases? Well, this study looked at the risk of myocardial infarction or stroke after a recent respiratory infection, looking at the database of over 2 million people, and found that if you've had a recent, i.e. within the last year, pneumonia, for example, your risk of myocardial infarction and stroke doubles. Now, why is that, you might ask? Well, we've talked about this issue in the past with other diseases, how recent pneumonia also increases your risk of having a pulmonary embolism. What's probably happening, I would bet, though I don't have data to prove this, is you're getting endothelial cell activation. There was a study in the New England Journal of Medicine a while back that looked at endothelial cell activation in patients with chronic gum disease and found that their endothelial cells were activated, which in turn is a prothrombotic state, which leads to more stroke. Now, why would I go on and on about this? Well, you could say that patients are having an inflammatory response to an infection, or in the parlance of those who give quack medications, patients are having a boosted immune system. When you take probiotics, for example, you get the same, albeit at a lower level, inflammatory response to taking large quantities of bacteria. Now, part of this could be seen as boosting an immune system. The other thing it could be seen as is causing an inflammatory response. And I would bet that people who take probiotics for prolonged periods of time have a small but increased risk of myocardial infarction and stroke. You heard it here first. Let's see if someone out there wants to do a clinical study to prove me wrong. Now, probably some hodgepodge stuff. This article concerns necrotizing fasciitis, specifically caused by Vibrio vulnificus. That'll be on your boards if you're a medical student going into medicine. But they looked at the clinical patterns of patients with Vibrio vulnificus necrotizing fasciitis. Not unexpectedly, most of them had hepatic disease, which is classic, but they also had diabetes and chronic renal insufficiency. The key thing is that those who went to surgery sooner had better outcomes. So if you had a fasciotomy within the first 24 hours, your outcomes were much better than those who had a delayed fasciotomy. The usual risk factors were the usual. They were either in contact with seawater or, here we go, raw seafood. So if you're a diabetic alcoholic with chronic renal insufficiency, sushi may not be the optimal dietary food for you. For those of you in South America, you know about Paracoxy brasiliensis, the used to be known as South American blastomycosis. The treatment of choice has been itraconazole for this fungus, but a study in Clinics of Infectious Diseases compared voriconazole with itraconazole and found them to be clinically the same. The voriconazole was dosed at 200 BID and the itraconazole 100 BID. The curious thing about this study is that they gave a loading dose of voriconazole even though they were expecting patients to be on the medication for 6 months to a year. It doesn't seem that 400 BID of voriconazole loading under those circumstances seems rational. But in case the patient doesn't tolerate the medication, they can get maximal expense up front. But response rates and side effects were the same in both groups, so it would appear that voriconazole is a, albeit more expensive, but equivalent treatment for the disease paracoccidioidomycosis. And I'm sure glad this is an oral presentation because I don't think I could spell paracoccidioidomycosis. When you think of intravenous catheter infections, you think of staph species. But this is not always the case. In a study published in Critical Care Medicine, they looked at the microorganisms that were responsible for intravascular catheter-related bloodstream infections and found that if you had a femoral line in, you were more likely to have gram-negative rods and you were more likely to have yeast as a cause of your catheter-related infection. For example, for gram-negative rod infections, there were 38% from the femoral site versus 8% from other catheter sites. And for yeast, 17% were from femoral sites versus 2% for other catheter sites. The groin, I suppose, is a filthy area filled with aerobic gram-negative rods and yeasts. Makes you wonder how we ever reproduce. But the take-home message is if you are suspecting a femoral line infection, it would not be unreasonable whilst you're awaiting the results of your cultures to start the patient not only on anti-staphylococcal therapy, but aerobic gram-negative rods and even fungal infection therapy. We have talked in other podcasts how delay in treatment of fungal infections, especially bloodstream candidemias, increases in hospitable mortality and in hospital mortality. The issue with antibiotics is frequently not the choice of empiric therapy, but the inability of most people to stop drugs once the cultures are back. Sometimes I think I'm the only physician in the hospital who's allowed to look at negative cultures and stop empiric antibiotics. I believe I talked in the last podcast how ESBL-producing Klebsiellas have 2 to 3 times the mortality rate of susceptible organisms. This time I just mentioned that multi-drug-resistant Acinetobacter baumannii has an increased mortality rate, about 1 in 3 compared to 1 in 4 who don't have that organism in their blood. And people who had multi-drug-resistant Acinetobacters also had more prolonged and complicated hospital stays. Now, the usual rule of thumb in infectious diseases is that resistant organisms are less fit and perhaps, as a result, less virulent in causing infections. This has been shown not to be true clinically in the plague of MRSA that we are seeing in the world right now. Here, a resistant strain has become the predominant strain and seems to be more fit in the environment than susceptible strains. In a study that was published in Antimicrobial Agents and Chemotherapy, they looked at Pseudomonas aeruginosa in bloodstreams infections and found that despite the fact that often these had multiple drug resistance mechanisms, one organism had 7 different resistance mechanisms, they showed no decrease in their virulence. So the hope that increasing resistance may lead to decreasing fitness and virulence in human beings is probably not going to end up to be true. And so we can continue to look forward to increasing resistance, fewer antibiotics, and more infectious deaths. Anybody want to consider, hand hygiene? Nah, that would be easy to do. Why get above 20% success rates with that simple procedure? An ongoing theme in all my podcasts is that no good deed ever goes unpunished. Gastric acid is important in preventing gastrointestinal infections, and the organisms die when they are exposed to stomach acid. However, people have GERD and gastric upset, etc., and as such, they often take drugs that interfere with acid secretion. There was a recent study that looked at the use of PPIs, protein pump inhibitors, and the subsequent risk for developing bacterial gastroenteritis. And they found that both Campylobacter risk and Salmonella risk went up if they were on PPIs, but not, interestingly, H2 blockers. The risks increase as the dose of the PPI increase for both omeprazole and lansoprazole. I can't pronounce these damn drugs. They're not antibiotics. Lansoprazole. Lansoprazole. Not even going to bother. But neither cimetidine nor ranitidine showed any increased risk in this study, which consisted of a grand total of 6,400 patients. They also did not, though this has been shown in other studies, to have any increased risk for Clostridium gastroenteritis, although they did have 31 patients with that in the study. So the take-home message, PPIs increase your risk for Salmonella and Campylobacter gastroenteritis, and I cannot pronounce drugs that are not antibiotics. I remember as a medical student reading a pharmacology textbook asking my dad, "Dad, what's theophylline?" He said, "We pronounce that theophylline." Well, then how come it's pentoxifylline? And it's debride, not debride. Debride is the woman who walks down the aisle of the church. And it's cefazolin, not cefazolin. There, I've had my say. I'm aware we're at the 31-minute mark, and I try to keep this to half an hour, so we'll plow ahead with some quickies of things that I think are of interest. The first is 37,558,179. What does that number represent? The war debt per household in the United States? Well, we're getting close, but not yet. It's actually the number of animals legally imported into the United States between 2000 and 2004. And I have been told, though I cannot confirm, that the illegal trade of animals is bigger than the drug trade in the United States. With these animals come infectious diseases. I think that's an amazing number, and I want to mention a couple of interesting fish-borne infections reported this month. Going to Vietnam? I'd like to, but be careful of what you eat in that. Fish-borne liver flukes are incredibly common in that part of the world. They did a study, which was published in Emerging Infectious Diseases, where they looked at random patients in Vietnam and found that 50% had Clonorchis, the liver fluke, and a significant number had other parasites as well, primarily from the tradition of eating raw, wild, and farmed fish in that part of the world. Love sushi. But if you happen to go to Vietnam, it would probably behoove you to eat your fish cooked. Well, the heck with that. I'm not going to go to Vietnam and eat raw fish. I'm going to just go to Taiwan and catch fish. Well, there was an interesting outbreak, and I want someone to tell me what this is. There is such a thing in Taiwan as a gambling fishing pond, as opposed to a regular fishing pond. And in this gambling fishing pond, people were getting an outbreak of atypical Mycobacterium tenosynovitis, especially marinum, that was associated with getting penetrating injuries from the fish spines into their hand. These were all acquired from the same gambling fishing pond. Now, I Googled gambling fishing pond and only found this article. So someone out there, please tell me, when you gamble at a fishing pond, what are you gambling on and why? Inquiring minds want to know. But don't think going to Africa will get you any better, because there was a outbreak of Diphyllobothrum latum associated with eating raw perch. Bon appetit. Coming soon to a hospital near you is XDR-TB, i.e. extensively resistant Mycobacterium tuberculosis. Now, this organism has been seen in Asia and Africa, and there's another strain that has developed in the last decade in South Africa, where there's now a virtually pan-resistant strain of Mycobacterium tuberculosis. This occurred for two reasons. One, they had directly observed therapy, but they didn't do susceptibility testing of their tuberculosis. And two, there was an HIV-susceptible population that helped spread the disease, because they worked on the assumption that the loss of fitness of drug-resistant strains would limit the transmission of tuberculosis. But in this case, the drug-resistant strains had an immunologically bankrupt population in which to spread. And as a result now, there's a pan-resistant tuberculosis strain in South Africa. The effects of drugs on these is minimal at best, and most patients with XDR-TB die of the disease. There's a nice editorial that accompanies this article called Extensively Drug-Resistant Mycobacterium Tuberculosis. Charles Darwin would understand. And the final paragraph, I think, is worth quoting here because it's so depressing, and it applies to staph and E. coli and Klebsiella and Pseudomonas. Quote, in roughly 55 years, we have squandered our precious legacy of chemotherapy for these XDR TB cases. Darwin, though, would understand. End quote. But we continue to do this for all organisms all the time. We give antibiotics, we give them badly, we breed resistance. And we are slowly but surely sliding into the post-antibiotic era. 2 quickies. One is a meta-analysis / systemic review of aminoglycosides suggests that they should only be used for urinary tract infections as monotherapy. Outside of urinary tract infections, monotherapy with aminoglycosides is associated with probably higher mortality rates and higher failure rates. So aminoglycosides should probably not be reused outside of UTIs. And then there's a nice review on delusions of parasitism in the clinics of infectious diseases, a interesting problem for those of you who have to deal with people who think they are infected with parasites and they are not. So as we end the last podcast of 2007, I would like to take this opportunity to wish all dozen of my listeners a non-denominational, generic, seasonal greeting, and to thank you for listening to this nonsense. This is the Persiflagers podcast, to review the infectious disease literature with commentary for the first 2 weeks of December 2007. Remember, now that you plowed through this nonsense, you can get a free half an hour of CME credit. Just take the online quiz at Pusware.com. Brought to you by the Persiflagers Annotated Compendium of Infectious Disease Facts, Dogma, and Opinion, your uber-hyperlinked guide to infectious diseases at Pusware.com. If you like this sort of nonsense, go listen to my Quackcast, a review of scams, available on iTunes. And hey, go put some stuff in the ID Wiki. That can be linked from my website as well. Bandwidth ain't free, so feel free to purchase the compendium and support the podcast. This is copyright under the Creative Commons license, creativecommons.org. The music is when my son was 12 years old, improvising on the guitar. And finally, thank you, as always, for this most interesting consultation, allowing me to participate in the care of this most difficult and challenging case. I will continue to follow along with you. Thank you. In dictation. Goodbye.